Hello all. In this session, we'll be learning about how to assess diagnostic stewardship program. That is leveraging the laboratory to improve antimicrobial usage. We'll be hearing learning about how to measure the impact and effectiveness of diagnostic stewardship programs. Let us first understand the dimensions of quality of care. It includes safety. It should be safe. It should be effective. It should be patient-centered. It should be timely. It should be efficient and equitable. So that's about the dimensions of quality of. Why to do assessment of a diagnostic program or antimicrobial stewardship program? Data plays an important role in assessing the interventions. It is necessary to identify the problems or evaluate the benefits of interventions. Therefore, efficient prioritization of interventions and allocating resources for the programs tend to demonstrate the impact of interventions. The progress in implementing this diagnostic stewardship at the site must be monitored and evaluated, and adjustments are made as needed to achieve the objectives of the program. Now, why to do assessment? It involves collecting and analyzing data as well as researching, onboarding, and effectively utilizing new tools and technologies. It involves re-evaluating how resources are used, such as radiological procedures and lab tests and others. It requires developing and implementing an effective financial strategy. These efforts can help improve patient management and outcomes, but they can also help the infectious disease diagnostic industry decide which innovations to prioritize next and how to improve the accuracy and accessibility of diagnostic tools. Let us understand the core components of this program. The most critical component is leadership commitment, then actions, education, training, monitoring and surveillance, reporting and feedback, and accountability and responsibility. To understand our leadership commitment, it involves dedicating necessary human, financial, and information technology resources, promoting a multidisciplinary approach, strategic and clinical leadership, drive the improvement, empower the nurses or midwives to engage with and influence the antibiotic management, governance within the hospital's quality improvement and patient safety governance structure, clear lines of accountability between the chief executive, clinical governance, drug and therapeutic committee, infection prevention control committee, and other such programs committees. What are the elements for consideration and prioritization? It involves educational programs, but with active intervention. It is said that eyes can see what a mind doesn't know. Knowledge is very important. Guidelines and clinical pathways seek multidisciplinary involvement and approval. Incorporate local antimicrobial resistance patterns, provide education and feedback to the practitioners. One of the first duties of the physician is to educate the masses not to take medicine, was the quote quoted by William Postler, and rightly said. Explanations about resistance and optimally prescribing antimicrobials is required in this program. Educate the colleagues about the appropriate use of antimicrobials, especially in relation to specialist area. Encourage the patients and other colleagues to question suboptimal antimicrobial management and documentation. The patient is centered around by nurses, doctors, and pharmacists, and they should be educated about the resistance and optimal prescribing of antimicrobials. The multidisciplinary team in this antimicrobial stewardship program involves IT specialists, infection control practitioners, microbiologists, intensivist nursing, surgery infection experts or surgeons, quality department, IT personnel, clinical pharmacists, and administrative representatives. What's the scope of the work for clinical staff? It involves development, adoption, and implementation of the practices, including local guidelines and SOPs. Then for the microbiology staff, it's to review and oversight the training needs and activities, including support to supervision for diagnostic stewardship. For the surveillance staff, it includes promotion of good diagnostic stewardship at referral sites and monitoring of the progress of the activities. Since it involves recording the receipts and ensuring processing of the specimens according to SOPs, read and record results, timely results and patient management, on-call services for requests, provide accurately and timely data. For the clinicians, they are the local champion. They should ensure that the correct indication is there for the correct sampling, ensure complete and correct clinical, demographic, and epidemiological patient information. They should be able to interpret and act on the lab results to optimize the patient management. While the infection prevention's role is to do surveillance and prevention and for transmission of for preventing transmission and cross transmission of multi-drug resistant organisms and to promote hand hygiene. While the clinical pharmacist role is to monitor antibiotic use and dispensing. Then the director's role is to do audit with interventions and feedback, streamlining the de-escalation guidelines and the clinical pathways. The clinical staff role is to collect specimens, label the specimens, ensure transportation, collection, and storage according to guidelines. About the different roles and responsibilities of the staff, let us see in detail about each of the responsibilities of each of these categories of staff. Surveillance staff, as said before, they should ensure appropriate compilation and analysis of patient clinical, demographic, epidemiological, and microbiological data. They should ensure the dissemination of compiled and analyzed results to all the healthcare workers and lab staff at the facility. They should ensure the reports are transmitted to staff for developing treatment guidelines and ensure transmission of regular reports and alerts to the National Surveillance Center. This is how the flow, the model of antimicrobial prescribing pathway and organization looks like. It's adopted from a program of Scotland. The convening of regular team meetings is required to present and discuss the lab results and related issues, present the progress in implementation, and identify and address administrative, technical, and operational and logistic issues. Then establishment of links with stewardship program, infection control program, and diagnostic centers. Now, what are the different treatment guidelines available, like ICMR guidelines or standard treatment guidelines from Stanford and other such international national organizations to be followed for developing and implementing the interventions. We'll discuss about few interventions in detail in the next slides. To start with, let's see about formulary restriction with pre-authorization. Formulary restriction means the restrictions may be placed on the prescription of antimicrobials on the hospital formulary according to approved criteria. These will have the specific indications, prescribers, services available, and for the patient populations, or a combination of each of these. Pre-authorization means the pre-approval of orders before dispensing should be there in place. Prospective antibiotic restriction, as who can prescribe an antimicrobial and acceptable criteria for use of the antimicrobial should be in place. However, neither of these strategies are mutually exclusive. It can be a combination of either. Then we have AWARE classification to improve availability and access to antimicrobials. AWARE stands for Access, Watch, and Reserve, wherein access antibiotics should be available at all times. Watch includes antibiotics recommended as the first or second choice of treatment for small number of infections, prioritized targets of AMS and monitoring. But restricted or reserved antibiotics include antibiotics such as coristin, polymyxin, tigecycline, which are reserved for the exceptional cases only. So access group of antibiotics include antibiotics like amikacin, amoxicillin, doxycycline, gentamicin, and others. The target is to reach 60% by 2030. Antibiotics include antibiotics like cefotaxime, azithromycin, meropenem, peptide, tazobactam, teicoplanin, and others. They have the highest resistance potential. They include most of the highest priority agents in the list, and they are key targets of the stewardship programs. Antibiotics include antibiotics like coristin, fosfomycin, polymyxin, and others. Now, antibiotic, what is an antibiotic timeout? What are the supplementary strategies? It includes antibiotic timeout. Antibiotic timeout is a reassessment of the continual need and choice of antibiotics 48 hours after initiation of the empirical antibiotics. Now, what are the questions that should be answered? Does the patient have an infection that will respond to antibiotics after 48 hours of the empirical therapy? If so, is the patient on the right antibiotic and according to the right dose and route? Can a more targeted antibiotic be used? How long should the patient receive the antibiotic? At day 3 of the antibiotic use, the order automatically should expire. Prescriber alerted and prompted to complete the continuation of antibiotics. A template recommended should be there in place for either continuation or discontinuation of the therapy. How results should be reported. How rapidly provisional results will be communicated is important. The on-call availability of lab staff, the provision for regular meetings to discuss results for individual care, to facilitate development and adaptation of local treatment guidelines, to address performance and challenges, timely reports including interpretive statements effectively applied for patient management, storage of reports and accessibility in patient files. Lab must also report negative results too. A microbiology laboratory may choose different approaches such as selective reporting, preliminary results, alert results. Selective reporting is like cascade reporting, when reporting when cascade methodology is used for reporting specific antibiotics only. Preliminary results should be put in place for the communication as they are available. Alert results should be used to communicate to the clinician the critical results such as gram stain and initial growth of bacteria. Reporting of results, the lab staff should respond to any queries from the clinical staff. Clinical staff should be aware of the working hours of the lab staff. There should be joint ward rounds between the clinicians and the microbiologists. Regular multidisciplinary team meetings should take place to facilitate and improve collaboration and foster the mutual understanding. Audit tools should be used to find out who need to do now, what you do need to do now. Collecting information on existing practices together with information on appropriate practice is essential component to improve healthcare. Audit is the evaluation of the data to check performance. It helps to compare what you have done in the past or what you think you may wish to do in the future. So audit goals in this program should be specific, measurable, achievable, realistic, and time bound. So let's see the dimensions of the quality indicators again. The dimension of quality indicators include structure, process, and outcome. It is given by Dr. Averis Donabedin. The focus is shifting from the structures to the processes now. Structural indicators in stewardship, antimicrobial stewardship program and diagnostic stewardship program. Antimicrobial stewardship program, it includes availability of the multidisciplinary team, availability of guidelines, provision of CME, surveillance of resistance and antibiotics, provision of checklist, availability of the list of restricted antibiotics. But in diagnostic stewardship, it includes availability of the diagnostic stewardship team, availability of rapid diagnostics, availability of checklist, availability of guidelines, policy that requires nurses and prescribers to draw microbiological samples for antimicrobial prescriptions, policy that requires prescribers to document any indications in the medical record for investigation done, and availability of trained staff. So that was about the structural indicators and DSP. Now, what are the process measures? There are very different process measures which include percentage of the patients who receive antibiotics, who receive restricted antibiotics, what is the de-escalation percentage, what is the dose adjustment percentage, adherence to documentation. And in diagnostic stewardship, it includes sample suggested percentage, appropriate samples received, who received a microbiology test, revision of antibiotics based on tests, and other such. Process measures assess how often patients are prescribed unnecessary duplicate therapy. It assesses how often patients are discharged on current antibiotics. It's performing a medication usage evaluation to assess the courses of therapy for selected antibiotics or infections. Process measures is time to effective therapy, also include time to effective therapy, time to de-escalation or de-escalation. Different indicators of antimicrobial usage such as documented indications for antibiotic usage, stop date or review date or compliance with the antibiotic policy or length of therapy by indications. So these are in details of the indicators about how much is the percent of patients with written indication, how much is the percentage of patients with a stop date or review date, the percentage of patients with indications for the correct for the antibiotic prescribed, and others. The process will also includes phototar review, de-escalation or escalation, IV to oral switch, surgical prophylaxis within the previous 60 minutes of surgery. Outcome measures. We have seen structure and process measures. Now let's see the outcome measures. Patient outcomes such as length of stay, mortality, morbidity, and clinical failures and readmissions are comes among the patient outcomes. While related to AMS for diagnostic program, it includes defined doses, duration therapy, days of therapy, microbial outcomes, include percentage of drug resistant pathogens. The difference between the output is an outcome. Outcomes comes after the out is a result of actually the output. The output is the things we do, and outcomes is the results that is expected after the output. It shows the success loud and clear. So this is how the chain looks. Input, we provide the input, the activities are done, we get the outputs, and the outcome is the final results of the output. This is in details about this about the flow, input, activities, output, and outcome. To balance the measures, are the challenges causing new problems or pre-authorization or delays in therapy or increase in adverse drug events or increase of allergic reactions and other such, and it should be done at regular. That's all about in this session. We'll see in details about this topic in the next session. Thank you.